Good evening, everybody. Sorry for the undue delay in starting the class. A few of the topics which were left out in the earlier ENT discussion, we will try to cover it today. To start with, laryngomalacia is our topic. So, it is a pressing problem for the patients, for the parents of a neonate who is just born or who is just born within 2 weeks and is starting to have noise while breathing. So, this type of picture where a very small child who is a neonate less than 2 weeks has giving lot of noise during breathing, which is especially aggravated by the position of the child in terms of the child is prone or if the child is crying, suddenly there appears a noise while inhaling, and that is most commonly is because of laryngomalacia. There are few definite causes for appearance of stridor, especially inspiratory stridor in neonates, and among them laryngomalacia is the foremost, or that is the most common cause for congenital anomaly of the larynx as well as congenital stridor. So, what exactly is happening in case of laryngomalacia? If you look at the larynx, that is especially the neonatal larynx who is having laryngomalacia, there is excessive flaccidity of the cartilages, especially the epiglottis and the supraglottic cartilages, arytenoids and the aryepiglottic folds. If you look carefully, the appearance of the epiglottis will be like that of a omega. So, omega shaped epiglottis which is easily sucked in during the inspiration because of excessive flaccidity of the tissues is the typical picture that we can appreciate when we are doing the flexible endoscopy, which is the diagnostic procedure to understand the pathology of laryngomalacia. So, if you look at these serial pictures, this is while exhaling, and during inspiration the epiglottis is drawn inwards as well as the arytenoids, so that the lumen of the larynx is very much narrowed, which is causing the noisy breathing during inspiration, and if you appreciate, it looks like an omega shaped epiglottis, which is the characteristic of laryngomalacia. So, apart from this, there is no other obstruction per se, and it is just because of the flaccidity of the cartilages which are there in the neonate, which are yet to be developed. So, there is a fair chance of the child getting out of the stridor once we wait for the cartilages to mature. So, in most instances, laryngomalacia is a self-limiting disease which regresses itself within a span of say 6 months to 1 year time without any surgical intervention. So, the best thing that should be done for a child with laryngomalacia is to what you call counsel the parents not to worry about it, and it is not a life threatening situation, and it just dies down as the age progresses, advances, and that leads to maturation of the cartilages. So, in order that the maturation of cartilages is hastened, we may advocate calcium syrup and we may advocate the child to be kept in a position which is not aggravating the stridor. That is, if the child cries, then the stridor is appearing. So, we need to make the child comfortable and put the child in a lateral position or a supine position, or whatever the child is comfortable with, we should be able to keep the child. So, it is very rare that a child with laryngomalacia goes into what is called as cyanosis, because it is not a totally obstructive process that is there in the child. It is only enough to cause stridor rather than any cyanosis. But in case it progresses to cause cyanosis, then we may have to what you call intubate the child or plan a tracheostomy for a life threatening situation. And if that situation is arising again and again, then we may have to plan something called as arytenoidectomy to widen the airway, but which is very rarely required. So, laryngomalacia is the most common congenital condition causing stridor in children, and it is usually treated by reassuring the parents and giving calcium supplements to the child, and it is a self-limiting disease. In case it does not regress or it causes what you call a long-standing or a life-threatening respiratory obstruction, then we may have to plan a tracheostomy, which is a rare event, and we may do certain conservative surgical procedures like arytenoidectomy or supraglotectomy to increase the or improve the airway. So there is a pranam sign. If you look at this, these two are appearing like two folded hands giving a pranam. So this is called pranam sign in case of long tubular epiglottis, seen in case of omega shaped epiglottis, seen in case of laryngomalacia. Now we have to diagnose it either by direct laryngoscopy with a rigid laryngoscope or a flexible laryngoscopy, and floppy aryepiglottic folds are the characteristic features, and treatment is mostly conservative. Coming to the next pressing situation, especially in adults who are diabetic, is called malignant otitis externa, or it is otherwise called as skull base osteomyelitis. So in this peculiar situation, though it is called malignant otitis externa, it is not a malignancy. Rather, it is a infective pathology, especially caused by Pseudomonas bacteria in elderly diabetics or in those who are having immune suppression. So malignant otitis externa, please be not confused or what you call carried away by the term that it is a malignancy. It is not a malignancy, rather it is a severe inflammation caused by Pseudomonas where the disease behaves like a malignancy, that is, it is locally destructive in nature. So if you look at the patient is having severe pain in the ear which is affected, and if you look at the external artery canal, you will see a very small granulation tissue which is not in consistency with the kind of symptom, severe pain that the patient is having. So we need to be alerted, especially an elderly patient who is diabetic, whose diabetes is not under control and is complaining of severe pain, and you look at the ear, you see very small granulation tissue in the external artery canal, which is not what is called apparently can be a cause for such a severe pain, then think of malignant otitis externa. Why this is important? Because once you ignore this condition as a trivial one, it can cause severe destruction of the skull base, that is the tissues lying in and around the temporal bone external artery canal, and it can even cause death because of rupture of the carotid artery, because the disease as it erodes the bone will expose the carotid artery, and there will be a condition or a situation where the patient may die of carotid artery rupture or intracranial spread of inflammation and infection. So we are to be very much what you call prudent in identifying the situation clinically, and this has led to what is called significance in entrance examination. So there will be excruciating pain and appearance of granulation tissue in the external artery canal, and this is the tympanic membrane, and at the junction of bony cartilaginous junction you will find granulation tissue which is reddish in nature, and if you try to clean them they will bleed on touch. So this is the granulation tissue in the floor of the external artery canal which can spread down and cause lot of bony destruction, and the reason that it can cause bony destruction, it is called malignant otitis externa. Basically it is inflammation of the external auditory canal or otitis externa caused by Pseudomonas infection. So a CT scan is a must for this condition, because in CT scan you will know the destruction of the external artery canal. If you look at this on the left side, this is the external artery canal whose bony walls are clearly visible. On the right side you do not see the external artery canal, rather you see a soft tissue lesion in the involved side. You will have to what you call serially subject the patient to a radiological investigation to know the disease process, and the best investigation to know the prognosis of the disease or the extent of destruction or inflammation that is going on in otitis externa. Gallium scan, that is CT scan, is the best thing because it avoids the radiation, because if you do serial CT scans again and again, that will cause lot of radiation. In order to avoid radiation, you can choose gallium scan so that you know these hot areas on the scan will indicate the extent of inflammation. So because it is a infection caused by Pseudomonas, we are supposed to eradicate the infection and control the diabetes, which is the predisposing factor. So first things first, it is the diabetes which is not under control, which has initiated the infection. So start controlling the diabetes, simultaneously attack the bacteria, that is Pseudomonas, by giving anti-pseudomonal penicillins like cycloxacillin, carpenicillin, or you can give the ciprofloxacin, which is the age-old medicine against the Pseudomonas, subjective to the what is called as evidence that the particular Pseudomonas which is infecting is what is called sensitive to the ciprofloxacin. The treatment has to continue for at least 6 weeks, 4 to 6 weeks, and in between you will have to take gallium scans to know the extent of inflammation, whether it is spreading or coming down. What if you don't treat? Then you can expect the disease to dissolve the bone, and then it can go intracranially. It can cause facial paralysis. We know that the facial nerve is coursing through the temporal bone, which may be exposed by the disease and can cause facial paralysis, and it may cause multiple cranial nerve paralysis as it is affecting the skull base. So treatment is high dose of IV antibiotics, cycloxacillin, third generation cephalosporins against the Pseudomonas. Next condition that we are going to discuss is myringotomy. As the name suggests, it is opening of the myringes, that is the tympanic membrane. That is a myringotomy is defined as surgical creation of opening in the tympanic membrane. That is incising the tympanic membrane for a purpose through a surgery. So where do you do myringotomy? There are specifically two conditions. One is to drain the suppurative inflammation and fluid in the acute suppurative otitis media, and another is to provide ventilation in non-suppurative otitis media or secretory otitis media where there is failure of eustachian tube. So these are the two conditions where we do myringotomy. There is usually a confusion where to do myringotomy, when to do myringotomy, and we need to it is a very simple procedure and effective procedure which we have to know the basics about it, because it is very commonly done in ENT practice. Now this you see, this is a picture showing the tympanic membrane, and there is a what is called gromate which is seen in situ. So it is a post-operative picture.